I also will be looking at the chat as well afterwards. If you have any thoughts, recommendations, or ideas about how we can do better to highlight challenges that might intersect between MPX and people's experiencing different kinds of disabilities, then that is something that I can also bring back to my team and also bring back to some of the state conversations to ensure that we can improve in those ways as well. So first, I'll start off with what is MPX? MPX is a disease that is caused by an infection with the MPX virus. That virus is related to the smallpox virus, although generally less severe than smallpox and much less contagious. It's not related to chickenpox, herpes simplex virus, or COVID-19. And on the right here, you see some different photos of what MPX can look like. It can vary from one lesion to many lesions. The rash can look a little bit different on different skin tones as well. And so those different kinds of presentations of the rash might look different. And so it's important to think about what risks might be there for the possibility of having contracted MPX. Part of the reason that we're talking about MPX is that we're seeing increased cases in California. In California, there are 3,369 cases from local health jurisdictions or counties as of August 26th. Among those with data, it's primarily cisgender males who identify as gay, primarily aged 20s to 50s, and so far the majority have not required hospitalization. With that said, although they might not have required hospitalization, there are reports of people experiencing very painful lesions and that can last for 2 to 4 weeks. And so it can cause significant pain and discomfort. On the right, you can see the epi curve, which shows cases going up over time since May. The reason why this is garnered, or part of the reason it's garnered a lot of interest is and information around this is because prior to May, it really we have not seen as many MPX cases in Europe or in the United States or in California. I also want to note towards the end on the right, you see what might look like a gray bar or a thick bar going down. And that's to highlight that information is still being reported across those later dates. So that's not complete information. So where you see the cases are going back down, additional information and reports of cases might show higher case numbers when all that data comes in. Risk factors so far in this aggregated data have included international travel, close or intimate contact with somebody known to have MPX, and also participation in venues with multiple sexual partners, including at bathhouses. With that said, it's important to recognize that any person could get MPX, regardless of sexual orientation, regardless of gender identity. And we'll talk a little bit more about the way that MPX can spread. But first, I'm going to talk a little bit more through data. This, I'm showing the 10 counties in California with the highest number of cases currently. So the top you see is Los Angeles with over 1,000 cases, followed by San Francisco, San Diego, Riverside, and you can see down here the top 10. On the CDPH website, you can find additional information about other counties and their case numbers. In terms of age across California, the primary group that we're seeing cases are between the ages of 25 and 54. You can see that that makes up the majority of cases here, although we have seen cases in those 18 to 24, as well as 6 cases in children under the age of 18 years. And older groups as well have also experienced MPX 55 and older, but the majority are between the 25 and 54-year-old age group. In terms of race and ethnicity, 40.6% of cases are in Hispanic or Latino individuals, 36.4% in white individuals, 12.6% in Black or African American individuals, 6.7% in Asian individuals. So you can see the race and ethnicity breakdown in this chart. One thing that I typically mention when we're looking at data like this is that what's reported here are the cases, which means that somebody would have had to be tested or their lesions would have had to have been swabbed and come back positive to enter this chart. What that means is that if there was disparities in access, meaning somebody didn't have a healthcare provider to get tested, or they had another reason why it was challenging to get into a healthcare office and be swabbed, they may not be represented in this data. And so there might be individuals who have had MPX that are not fully represented in these in this data. And we always have to be conscious of disparities, challenges with access that might be reflected in our data. In terms of gender identity and sexual orientation, there's more information also on the CDPH website, but as you can see, 97.5% of individuals identify as male and 85.3% identify as gay or same gender loving. You can find more information, including how many people identify as female or transgender male, transgender female. That information is here on the website, but altogether they make up around 2.5%, the remaining percent. So how might somebody come in contact with MPX? It's primarily through close personal, often skin-to-skin contact with people who have MPX symptoms like rashes and sores. In these outbreaks, that is the primary way that we're seeing MPX being spread. Theoretically, also possible through touching materials used by a person with MPX that haven't been cleaned, like clothing and bedding, or through respiratory secretions, like talking, coughing, sneezing, breathing during prolonged close face-to-face contact. Or for instance, via kissing. However, this close skin-to-skin contact, as I mentioned, is the primary way that we're seeing in these outbreaks. It has not been found to spread through casual conversations or walking by somebody with MPX, like in a grocery store, or by touching items like doorknobs. In terms of signs and symptoms, it might start with symptoms like the flu, what are called prodromal symptoms. They're flu-like symptoms like fever, low energy, swollen lymph nodes, which might feel like marbles, or general body aches. The incubation period, meaning the time from somebody being exposed to the time that they start to have symptoms, is typically somewhere between 3 to 17 days, although it can be longer. And it's also possible that some people might not experience any of these initial symptoms and only experience the rash. In terms of treatments that are available, what's been found is that many people with MPX have experienced a self-limiting disease course without specific therapy, meaning that it gets better on its own in many people. So the management and treatment of MPX includes can include supportive care, which we'll talk a little bit more about, and treatment of symptoms. And the other side, if people are at high risk for severe disease or experiencing severe disease, might be able to get a medication called tecovirimat or TPOXX. TPOXX is a medication that was initially used and tested for smallpox viruses, but since smallpox virus and MPX virus are similar, it's also been found to be potentially helpful for MPX as well. So first, in terms of the supportive care, it's important to address the pain and discomfort that people with MPX might experience. A lot of pain might exist, for instance, from what's called mucosal lesions or lesions that are in the mouth, but also in the genital area or by the anus. There are topical, meaning therapies that can be used just placed on the skin, as well as systemic strategies, which are things like medications that people could take that can help address the pain and discomfort and these symptoms. One option is what's called a sitz bath, which is where you sit in a warm bath that can help with lesions, particularly in the genital region or by the anus. Saltwater gargles, so gargling with salt water can help with the lesions in the mouth. Steroids that are applied to the skin, or lidocaine, which can help with pain and numbing. There's also over-the-counter medications like Advil or Tylenol, as well as prescription pain relievers that a healthcare provider might prescribe. An example is gabapentin, which helps with pain. And so talking with a healthcare provider about the symptoms that you might have or that you're experiencing, they might be able to help prescribe medication that can help with those. In addition to some of these other options, a stool softener can help with proctitis, so inflammation around the prostate, in order to make it not painful when somebody's going to the bathroom. And then for some people, if these things are not helping with pain or they are having severe disease, TPOXX might be indicated. So this gives some information about who's at risk for severe disease. The first group is people that with immunocompromise, so people that might have HIV or AIDS, certain cancers, autoimmune disease, or on medication that lower their immune system. Children, particularly those less than 8 years of age. People that have a history or a presence of certain skin conditions like eczema or burns, herpes simplex virus or severe acne, they might be at risk for more severe disease. And then people who are pregnant or breastfeeding. So these would all be people that if they got MPX might be considered for TPOXX therapy. So this gives a little bit more information about TPOXX. It has been studied and shown to be effective in animals. However, studies are still being conducted to better understand how effective it is in humans. And that's why it's still under what's called an IND, an investigational drug protocol, because it's still being investigated. And so when the medication is coming, it is coming from a national stockpile that's then allocated to the states. The state allocates it to the local health departments, and then the local health departments help get it out to healthcare facilities to treat patients who are eligible. It's the medication is 14 days of oral capsules. That's the preferred route, but if needed, there is also an IV method as well if somebody is unable to swallow. There's also an option for children under 28 pounds. The capsules can be opened and mixed with foods. If somebody is positive for MPX, they can be contagious, or the disease can spread from the time that the symptoms start until all symptoms have resolved, including full healing of the rash with the formation of fresh layer of skin. And that can take somewhere between 2 and 4 weeks. When somebody does have symptoms, including the respiratory symptoms and the rash, they should remain at home or in isolation unless they're seeing a healthcare provider or unless there's an emergency. So you'd want to avoid close or physical contact with other people and animals like pets. You'd want to cover lesions with clothing or bandages. If you are around other people in the home, you want to wear a well-fitted mask and also avoid public transportation. If you're not able to remain fully isolated throughout the time that you're contagious and your respiratory symptoms go away, but you still have rashes, during that time, you still want to be avoiding sharing utensils or cups. Those items should be cleaned and disinfected before others use them. You want to make sure that you're not sharing clothing. You want to launder or disinfect items that have been worn or handled and surfaces that have been touched by a lesion. You want to wash hands with soap and water or use alcohol-based hand sanitizer, and avoid close physical contact, including sexual or close intimate contact with other people, and avoid crowds and congregate settings. If somebody is exposed to MPX in the community, you can still continue your routine daily activities, meaning going to work, going to school, as long as you don't have signs or symptoms of MPX. but you want to be monitoring yourself for 21 days after the last time that you were exposed, meaning checking your skin for any signs of rashes. If a rash does occur, then you would want to isolate and get checked by a healthcare provider to see if you should be tested for MPX, if the rash is consistent with MPX. If you're getting other signs or symptoms like the flu-like symptoms, like a fever, or symptoms that are not yet the rash, but the swollen lymph nodes, you would want to isolate for 5 days to see whether or not a rash presents. And if those symptoms go away and don't progress into a rash, you may be able to leave isolation. But if they do develop into a rash, or if you're concerned that it might be MPX and the symptoms are getting worse, again, you would want to talk with your healthcare provider and get tested to see whether it's MPX. You shouldn't donate blood, cells, tissue, breast milk, or semen while you're monitoring. And after you're exposed, you might also consider contacting either your healthcare provider or the county health department to see whether you can get a vaccine for post-exposure prophylaxis. So switching to talking about the vaccine, it's a 2-dose series, 28 days apart. But in most areas right now in California, the first dose is being prioritized, which means that it might take a little longer to get the second dose. And the instances where somebody might be getting 2 doses is if they're immunocompromised, for instance, and the thought is that the first dose might not be as protective, then they might also get their second dose. For other people, we might be extending past the 28 days to ensure that we can vaccinate as many people as possible with their first dose. The vaccine doesn't contain any material of direct animal origin. It's formulated without preservatives, and it's not made with natural rubber latex. And there are not any CD4 cutoffs, meaning somebody who has HIV that their CD4 count is low, they can still safely receive the vaccine. But there is limited supply of vaccine throughout the country, and each local health department might have a prioritization schema that's slightly different. So again, it's best to contact your local public health department or look at their website to get a better idea of who is within the priority groups to get vaccinated at this time. An update on the vaccine. So you may have heard of a different way or a different route that the vaccines are now being given. It's called an intradermal option. On August 9th, FDA authorized this intradermal pathway. And what that allows is for 1/5 of the dose to be used in order to vaccinate. So with that, there's the potential of having up to about 5 times the amount of vaccine per vial, although sometimes it's been found to be a little bit less. So we might not get those full 5 doses from each vial, but certainly it allows for an expansion of the amount of people that can be vaccinated when we use that route. Somebody who is over the age 18 or older who received the vaccine with the subcutaneous regimen, so meaning the way that it was being done initially, can get their second dose with the intradermal regimen. And a person whose 18th birthday occurs between their first and second dose can complete their series with that intradermal option as well. However, there are a couple of groups that should not be getting the intradermal route. And that would be children and young adults under the age of 18. They should still get that initial subdermal type of route. And people who are prone to keloids should still be getting the subdermal route as well, not the intradermal. So when I talk about intradermal, what I mean is a vaccine that is given similar to the way that the TB skin tests are done, meaning it's on your forearm on this side here. This is where they would be giving it for an intradermal vaccine. Switching to some prevention strategies, the recommendations are to talk with your sexual partners about any recent illness and be aware of any new or unexplained sores or rashes, including on the genitals and anus. You want to avoid close contact, including sex, kissing, or cuddling with people with symptoms like sores or rashes that could be MPX. And people who have MPX should isolate until their symptoms, including the rash, have gone away completely. Practicing good hand hygiene, using appropriate personal protective equipment like a mask or gown and gloves when caring for others with symptoms, and avoiding contact with infected materials contaminated with the virus. So things like cups, clothing, bedding, or towels that might have been used by somebody who has MPX. I'm also including here, it's a number of different links that I'm happy to share of updated guidance and information put out from CDPH, which is the state, as well as CDC. That includes guidance for homeless service providers, guidance on home isolation for the general public, more information about the intradermal vaccination route, information about how to protect yourself and your community. And then from the CDC, there is a link here that if you go to the CDC website, they have one place where they have all their newest and most updated guidance. One of the recent studies that came out talks about the impact of individuals reducing the number of sexual partners that they have, and the potential or anticipated reduction in MPX cases as a result. There's another study here that talks about household surfaces, and what they found was while MPX virus might be found on household surfaces, if disinfection and cleaning is ongoing, those virus particles have not seemed to be transmissible. So it's virus that can't infect somebody. And then there's updated guidance around persons with HIV, about guidance for people that have pets in their home, on schools, early care and education programs, on congregate living settings, and then also additional considerations for MPX in children and adolescents. So I do recommend that you take a look at these websites if you want more information, as well as your local county website. And I'm going to transition over now to Misty for the second part of the update. That's a shorter part on COVID-19.
Thank you, Dr. Chevinsky. May I ask for your assistance in moving through the slides that we put?
Yes, of course.
Thank you. Okay, so on the slide in front of you, you see some recent state of California data for COVID-19 infections. In your local area, the county that you live in or work in, you may see different numbers related to the number of cases or the number of positive cases that keep circulating through with regard to percentage of test positivity. California continues to navigate through a response for COVID-19, providing testing support, treatment support, as well as in-home vaccination support across local health departments. In many counties, individuals who have challenges with transportation or access to clinics can get transportation support or in-home vaccination support. We continue to see vaccination clinics driving up the number of vaccinated individuals in the state. Over 80% of California's population has at least one dose of vaccine on board. We do continue to see positive cases throughout the state, with certain counties and areas maybe more affected than others, particularly counties with larger populations or populations that live closer together. We have 21.9 new cases per 100,000 population throughout the state, currently trending. And our later lag data indicator for COVID is our death rate. Our death rate has remained lower in the summer dates as we've moved further into the response. Unfortunately, though, we do still see deaths related to COVID-19 with about 33 on our daily average, which, considering where we have been, is an improvement largely due to vaccination and mitigation strategies. California as a whole has a 10% positivity rate for testing, And we do continue to use both antigen and PCR tests. Antigen tests you may be familiar with in the over-the-counter sense, or perhaps the tests that maybe you get from your insurance provider. They're the rapid tests that are done usually at home or very quickly at a workplace or at a school. With the data trends, the website that shows these boxes that we've put into this slide, that's linked to the slide here, so you can continue to see those trends, and you can also search by your local county to get specific information related to where you live or work. All right, Dr. C, can you hit the next slide? We do continue to vaccinate for COVID-19. We have 4 vaccines available for children as young as 6 months of age. Pfizer vaccine is available for 6 months and older, also provides support to children aged 5 to 11 and then 12 and older. The Pfizer vaccine is FDA approved for those that are 12 and older, so it has made its way through all of the application and approval processes. It is emergency use authorized for those 6 months to 11. Moderna also makes a pediatric vaccine that covers into infancy all the way through toddlerhood, so 6 months and older as well, covering up to age 12, and then again, the older populations. We also have the Janssen vaccine that we use selectively for individuals who may have an allergy to Pfizer or Moderna, or we use the Janssen vaccine to assist individuals who may not be able to be vaccinated any other way. The latest update is our 4th vaccine, that's Novavax. The Novavax brand vaccine is emergency use authorized for individuals 12 and older. Novavax is also a 2-dose primary series, much like Pfizer and Moderna. The doses are given 3 to 8 weeks apart. It is also an intramuscular injection, so usually up in the shoulder area or the outer thigh. And the Novavax vaccine has been in use globally since earlier in 2022 and has been able to assist individuals in getting COVID-19 immune protection who perhaps were not yet vaccinated between Pfizer or Moderna. We do ask that the Novavax vaccine not be mixed with other vaccines at this point. We would encourage individuals who choose Novavax to start and complete a Novavax series through its entirety. Updates in the world of COVID, also with what happens if you are sick with COVID or what happens when you are exposed with COVID. We now treat individuals based on whether or not you have symptoms of being sick or not have symptoms of being sick. If you were exposed to someone who has COVID, but you have no symptoms, you would assess your own personal risk, those that you care for or live with, wear a well-fitting mask between your nose and chin, and monitor for symptoms. But you no longer have to quarantine away from others unless you have higher risk individuals that you care for and that may be immune compromised. If you do have symptoms of COVID, however, you have flu symptoms, cough, fever, sore throat, we would encourage you to test immediately, ideally with an antigen test. Wear the mask and self-isolate while you await your test results. So stay away from others if you have symptoms, and then await your test results. If you have a positive test, you would stay in isolation for 5 days, and then we would want to see your symptoms getting better. No fever, ideally for at least a day before you go back out interacting with others and you're not taking fever reducing medication. And then wear a mask for the remaining 5 days. So again, a well-fitting mask, nose over the chin, a higher filtering mask would be ideal. Examples of those could be a KN95, or a KF94. Those are ideal, especially in the last 5 days of an isolation period. With COVID-19, the state of California will continue, as well as local health departments, to vaccinate and also to offer testing and treatment. Most counties have test to treat sites where they could test to determine if you have a positive result. You could work with a nurse or a telehealth consult and get evaluated for antiviral treatment to minimize your risk of severe disease in the event that you are COVID positive. Those treatment sites provide oral medication called Paxlovid. And Paxlovid is a series of pills that an individual would take for a prescribed period of time to help minimize their COVID-19 disease process. I think that covers the bulk of the updates for COVID. I'm happy to take questions and continue to support the panel. Thank you, Dr. C, for moving through the slides.
Thank you. And I'm going to transition over to Dr. Olga Solomon, who's a director at Community Education of USC University Center for Excellence in Developmental Disabilities at the Children's Hospital of Los Angeles, and an assistant professor of clinical pediatrics at the Keck School of Medicine of USC to help with the Q&A.
Yes, thank you so much, Dr. Chevinsky and Ms. Plumley. We are so grateful to you for coming and giving this update to our community. We feel that being informed is just so important for making sure that everyone has the best and the most current information. And this is our second listening session. We hope to continue as things kind of evolve and progress, to continue with this model, because we feel it's really the best way of bringing everyone together to kind of find out how everybody's doing, but also giving the information as it changes. So I have been collecting and compiling the questions. So I'm sorry, everybody, if the questions are not in order that you asked them in, but I'll just go with the most general one to the most specific one. So first question is it safe to receive so many vaccines, COVID, MPX, and flu together?
So I would say in terms of the larger idea of getting multiple vaccines, not only is it safe, but it's recommended, knowing that vaccines have really helped steer us away from many infectious diseases of the past and present. With that said, there are some recommendations in terms of timeline. So in particular, for the COVID-19 mRNA vaccines and the MPX vaccine, the Jynneos, it is recommended that those two can be spaced apart if it is for prevention of MPX, meaning if this is a preventive vaccine not related to an exposure. However, if somebody is exposed, has been exposed for MPX, and this is a post-exposure prophylaxis to prevent the severity or potentially prevent getting MPX, then it is recommended that regardless of the timeline that you had your COVID mRNA vaccine, that you would still go ahead and get your MPX Jynneos vaccine. And Misty, I don't know if you wanted to add in anything else on that in terms of the timing between the MPX and the COVID-19 vaccine.
It's a great question. We can co-administer COVID-19 vaccine and the MPX vaccine together. They do use different sites, but we can maximize the protection, and the literature that we have currently shows the protective benefit of both with limited interaction. So it is a safe strategy to co-administer. And as we get closer to influenza season, I would say we can also co-administer MPX vaccine with flu vaccine as well.
Perfect. That kind of goes into the next question, which is, do you think the numbers will go up in the fall?
So if we're talking, I'm not sure if we're talking about MPX or we're talking about COVID, but we can talk about both.
Yes.
And while it's challenging to predict because of the dependence on a number of factors, so I can talk about some of the factors that might influence case rates without being able to predict for you which way it may go. In terms of MPX, with increased vaccine, that will allow us to provide more protection within the community. In addition, we already have some studies from the CDC that shows that individuals are also changing their behaviors as well for harm reduction. And so the combination of harm reduction strategies and an increased vaccine uptake can allow us to help protect and prevent more MPX cases. And then in terms of COVID-19, I think similarly, it depends on vaccines and mitigation measures. So as we continue to increase uptake of vaccine in the population, and in addition, as individuals decide and think about ways to reduce their risk, meaning things like if you're indoors, increasing ventilation, keeping windows open, wearing a mask if you're in a location where there's more COVID-19 and you're in an indoor setting, so washing hands. So each of us plays a role in what those numbers might look like going forward, and our utilization of the mitigation strategies that we know that work in combination with the vaccines will help to influence what the numbers might look like in the future, and also depending on what variants might arise in the transmissibility. So
thank you. Okay, next question. If you work in healthcare settings or live with someone who does, do you need to get the monkeypox vaccine?
Yeah, that's a great question. Right now, and of course, categories might change, but currently what we're seeing is in terms of people who work in healthcare, we are not seeing spread via healthcare settings. And that's because of the use of PPE or personal protective equipment, which has been very effective at preventing spread from MPX. From an individual that has it to somebody who works in healthcare, or to those that live with the person that work in healthcare. Right now, in terms of the healthcare setting, the only people that are recommended to get the vaccine are providers that are routinely swabbing, like in an STI clinic, where they're having a lot more daily, for instance, and close interaction with specimens, like those that are doing the swabbing. And people that work within a lab that are directly handling specimens of MPX. Outside of that, meaning the majority of primary care providers, the majority of people that work in an ED, whether inpatient or outpatient settings, are not recommended to get the MPX vaccine at this time, nor their family members or people that live with them.
Gotcha. Thank you. Okay. If you're old enough to have gotten the smallpox vaccine, then do you need to consider getting the MPX vaccine? So
that still would be a consideration, particularly if it's been more than 3 years since the last time that somebody was vaccinated. So that in particular comes into place if somebody has risk factors, for instance, if they've been exposed to MPX and it's been more than 3 years since their last vaccine, we should still consider giving them a vaccine for post-exposure prophylaxis, for instance. But some of the data that we're seeing is that a vaccine that might have happened a long time ago when somebody was a kid might not fully protect them, although it might be somewhat of a lessened disease course that's still being studied. It's still may be possible for them to get MPX, and should still be a consideration if they're in situations where they might be at risk for contracting MPX. And then I just wanted to modify my answer to the prior one to add in for the healthcare workers. So what I was talking about was specifically prevention vaccine, so pre-exposure prophylaxis. However, if a healthcare provider is known to be exposed and have a high-risk exposure, then a post-exposure vaccine would be appropriate if they had a break in their PPE and their protective equipment. So for instance, if they were treating a patient with MPX and they were not wearing gloves or a gown or a mask, and they were doing a swabbing, for instance, then based off of that identification of a high-risk exposure, then they might get the vaccine.
Okay. Thank you. All right. Is the MPX vaccine out available for the general public? You may have
So,
mentioned that already.
yeah, the MPX vaccine, it's still in short supply around the country, and there's specific recommendations of who is at the highest risk for getting MPX. And in terms of who's getting vaccinated might differ from county to county. The principles are the same in terms of those that might be at highest risk, but in each county that might be a slightly different population of people based off of the demographics of the people that are living there. So I would suggest that you look at your county's website to get updated information about the people that fit within their vaccine strategy at this time.
Okay. And I think you probably already answered a little bit of that, but somebody is asking, Diana Poole is asking, if you got a smallpox vaccine this year, do you need to get MPX vaccine?
A smallpox vaccine this year.
Right.
So then, since it's within the 3 years, I would not consider, but I would double check and see whether you did get a smallpox vaccine earlier this year, because it would have had to be a pretty unique circumstance for which somebody would have gotten a smallpox vaccine earlier in the year. So I would just verify and make sure that that is the vaccine that somebody had gotten, and it wasn't like a chickenpox vaccine or something else.
Okay. Are we already being guided to treat COVID as endemic? So Sandra Aldana is asking, I don't see that yet in the data, but what are the current treatment guidances?
Yeah, so in terms of the term endemic, really what that makes us think about is what level of COVID-19 are we willing to live with on a day-to-day basis without it, for instance, causing a lot of havoc in our healthcare systems. So it really, there isn't a specific number or a specific time where we would say, oh, it's endemic and that's it. Really what the conversation is thinking about the balances of the risks and the harms to the community and the risks and harms to our medical system. And so that is the lens in which public health and healthcare facilities think about when they're thinking about COVID-19. And, as I heard some of the stories earlier on that people shared about their life experiences, it really puts into, focus the kinds of, suffering and harm that people have experienced by COVID-19. So we keep that in our lens and in our mind as we think about going forward, what the different recommendations around COVID-19 are. Okay,
thank you. So if someone is not self-identified, I think you already kind of answered that, but just again, if someone does not self-identify as LGBTQ, does that person need to think about MPX affecting them?
Yeah, well, I think that this answer, it has a couple of different parts. So first off, anybody can get MPX regardless of whether their gender or sexual identity. Right now, we are seeing heightened cases or elevated cases, particularly in cisgendered gay males. Although we have also seen some cases in females as well as those that are transgender men, transgender women. And unfortunately, we're also seeing cases now in kids too. So my two-part to this answer is one, we have to be thinking about MPX as a community because those that are being affected are part of our community. And so it's something that we should all be thinking about, but also that we see that there can be spread outside of, for instance, the LGBTI population. So thinking about that as well, because it's just a disease that can be spread from skin to skin contact. So I think we need to think about it broadly. Certainly, when we're thinking about strategies in vaccination, we want to think about the population that's being affected most right now. But when we're putting together guidance, we have to think about the fact that this can also spread in terms of early child education, congregate settings. Like any infectious disease, it does not know much about its host. It just knows that, it can pass from skin to skin in whichever location, in whichever place, and regardless of a person's gender identity, sexual identity, or other.
And Olga, you have about, it's 1 o'clock, so you have time for maybe one more question.
One more question. Okay. Have there been any issues that providers have had to deal with regarding misconceptions between MPX and other dermal lesions such as neurofibromatosis?
So that is a great question because the lesion itself of MPX can mimic or mirror other kinds of lesions. So neurofibromatosis was one example that you had just given, but also can look similar to a herpes lesion or a chickenpox lesion or a lesion from syphilis. So there can be some challenges with identifying that lesion. And in that case, the healthcare provider, typically what they can help to better understand is asking a good history. So getting a better idea of potential exposures, and then ultimately also potentially swabbing the lesion if it looks like it could be consistent, to get it tested for MPX.
Thank you. Well, we answered the absolute majority of the questions, and I think that in the interest of time, we'll take the other questions that we will not have time to answer and see if we can get answers for them, not live. But let me then pass on the floor to my colleague, Wesley Witherspoon, and he will close down our webinar today.
So I want to thank everybody for coming to this meeting we're having today, and hope everybody very best for the rest of 2022 and the rest for 2023. So thank you very much, and thank you.
Thank you.